Good afternoon, everyone. My name is Jessica Gorham, and I'm the Regional Emergency GBV Advisor based here in Nairobi, covering East and Southern Africa on behalf of the GBV Area of Responsibility. And I'm also the co-chair of the Regional GBV Working Group for East and Southern Africa. And I'm joined by my other co-chair, which is Laureen, who is representing CARE International, who is the co-chair also of the Regional GBV Working Group for East and Southern Africa. Today, we will be talking about the impact of the drought on women and girls, particularly the protection of women and girls. And we're specifically going to be identifying GBV risks. We're going to focus today's discussion on Somalia and Kenya specifically, because we will have a second briefing next week that will focus solely on Ethiopia. The briefing on Ethiopia will be next week. It will cover the drought, but then also the other crises in Ethiopia, such as Tigray. So we're not minimizing the impact of the drought in Ethiopia, but we also noting that we will have a separate webinar on or briefing on Ethiopia specifically next week, so bear with us. For those of you who are joining us for our first Emerging Practice webinar series, we hold these each month, usually towards the end of the month, and we like to highlight things that are going on in the region. And we particularly always highlight organizations who are doing the work on the ground. We're really pleased that today we have CARE Somalia, who will be presenting the results of a rapid gender analysis that was done in Somalia. And we will also have our colleague Kenneth Kamande from the Kenyan Red Cross, who will also be talking about their work in drought impacted communities in Kenya. So a little bit about logistics. If you have any questions for the speakers, if you could please write them in the chat. I will be monitoring the chat throughout the presentations and will present those questions at the end to our various speakers. We do, like I said, like to keep it to 1 hour, and we find if we're able to put like questions together, it gets us through those questions a bit easier. So please don't hesitate to write your questions to the speakers throughout the presentation in the chat. I will be monitoring the chat throughout, and during the question and answer period, I will then ask our specific or direct them to specific speakers. The presentations and a recording of this webinar can be found on the gbvaor.net website, and we usually put those up within a day or two. So if you're interested in sharing these with colleagues who were not able to join us today, please, you can find this webinar and all previous months' webinar on our global website, which is gbvaor.net. So without further ado, let's get started, because we do have a full agenda, as I said, and we've had a lot of colleagues really putting a lot of thoughtfulness into these presentations. I'm happy to introduce our first speaker, who is Martin Businji, and he is working for CARE International in Somalia. He is the country meal coordinator. Martin, I will turn it over to you.
Thank you very much, Jessica, and good afternoon, everyone, and good morning to the people that may not be in the region, East Africa, actually. And like Jessica has introduced me, I'm actually working with CARE International based in Somalia, and I'll be presenting the CARE Somalia Rapid Gender Analysis, the actual assessment which we did towards the end of the last year, and that was in August. And basically, I'll start with the scope. We did, this rapid gender analysis to generate information on gender roles and responsibilities, look at the capacities and vulnerabilities, and also look at the coping mechanisms during multiple crises, because we are looking at the drought, the COVID, conflict, and displacement. And we actually adopted a mixed method where we were basically looking at both qualitative and quantitative aspects, and we utilized the 5-step care process for the RGA, and the tools actually we adopted were for care, rapid gender analysis. And to be specific, we conducted household interviews. We did some focus group discussions, key informant interviews, and in video stories, together with document review. In total, the information I'll be presenting covered 2,437 respondents, and 72% were female. And we also did 51 focus group discussions, 26 key informant interviews, and 6 in video stories, actually. That's the scope of the study, of the assessment. And as you can see on the left corner, there is a map actually which shows where the assessment was done. We did not cover the entire country. We largely covered, Somaliland, Puntland, and some, areas around, Southwest State and Banadil. So to go to maybe some of the limitations as we go through this, we had some limitations, and I think you need to take care of them because they define what this data is able, to give you and what it may not give you. Basically, this assessment was largely, focused on adults. We talked to male and female that maybe were men and women, and not so much of children, but children maybe could come in here and there, at focus group discussion level. But at individual interviews, we did not interact with children so much. We also, faced the challenge of insecurity. Actually, data prioritized accessible locations. As you know, the challenges we grapple with in Somalia, we largely looked at, urban centers where maybe we are able to do programming. And I think in some other areas, we may not have, been able to go deeper and, talk to the deeper rural communities, especially, in areas around Southwest State and, Mogadishu. And then budget restrictions. Actually, this information covers largely, areas where care has presence. It does not cover areas maybe where we do not have presence. So we may be having questions. We do not cover everywhere as care. So the information is kind of, restricted to where care works. And then COVID-19, we did not basically have that, rigorous, engagement of enumerators. Much of, we did remote engagement. And then the time factor also had an impact because we were doing, this assessment during the day, and we'd find maybe some males were not in the home. So you'll find that maybe we talked largely with women because men had gone to maybe do some work or engage in their day-to-day business out there. And then interview fatigue can also be accounted for because we had, some people refusing to talk with us, saying that, organizations keep coming, they interview us, but we do not see any kind of benefit or anything that is tangible or changing in our communities. So as you are aware, this is a protracted crisis, actually the insecurity, and even, the recurrent natural disasters, somehow, the communities feel we are over-engaging them when it comes to these assessments. But out of the people we talked to, we realized that drought was the biggest shock actually that they were facing, and actually 78% came out clearly and pointed out to drought being the biggest challenge they faced. And majority of the people who were affected, according to what we got, were female-headed households, children, elderly, persons, actually IDPs, and disabled people, the people with special needs. And then we also found out that water, sanitation, and hygiene huge concerns actually, where we saw that 56% of the families had to travel more than 30 minutes actually to safely access water, because there are quite some stresses when it comes to water access in these communities due to a drought. Most of the sources which they were ordinarily using have dried up, so they have to walk and look for water, and sometimes they don't even get it. And we also saw that, 34% of women and 30% of actually men had no access to latrines actually. And, as maybe displacement becomes more intense, then there is a risk of having some disease outbreaks. And I think we need to look into some of these issues as we engage in our responses. And also we saw that 58% of the women had unmet hygiene needs actually. Much of these needs were, rotating around, the sanitary kits for women, because we were able to talk with women in IDP camps where they would come up very, candidly, and they actually confide in us and tell us that they are finding a lot of challenges, accessing some of these much needed hygiene kits, including actually the menstrual kits actually for women. And then for health systems, actually we saw that they are remaining quite weak, where we have 55% of the people were reporting that, healthcare was the highest priority need actually, and 62% of these were women. And I think you need to take note of this one. Women face a lot of challenges when it comes, to healthcare because of their reproductive health needs, and also, the burden of taking care of the children. So they were very, very, verbal when it comes to this whole situation of saying that, they need to see some of, the health interventions scaled up and also maybe expanded through mobile teams to reach to maybe some of the communities that are quite distant. And another issue we saw was around food security, where we actually found that 87% of the people prioritized food, because food is one of the major problems that they were facing with food insecurity. And they feel that maybe if agencies are coming in, they should be able to help them in accessing adequate food, nutritious food that can help them survive and they don't fall into a famine situation. So we saw that most families are eating less preferred food by that time, and more urban female-headed households actually, IDPs and AFMI speakers were the most affected. So the AFMI speakers, maybe for people who may not be knowing Somalia, they are largely in southern Somalia, that is the southwest state, and some parts of Mogadishu, which is Banadil. And then other priority needs that we saw included healthcare, actually reported by 55%, shelter for people who are being displaced due to the drought and other situations, the conflict and other factors, the clan conflicts at the community level. Then education is also a problem. Then protection, because women and girls were coming in, like during most of the engagements, girls would come in very keenly, and they tell us, we are facing a lot of challenges during focus group discussions, and we need, the organizations to come in and ensure that they deliver the much needed, protection physically, psychological protection in form of maybe where they are provided like counseling in case they have been abused, and other things, around like, the hygiene kits and the menstrual kits. And then violence is raising. That is true. 44% of the people said the concern around gender-based violence is quite eminent, and women's safety has actually increased since the onset of the drought, because we saw that so many women were being displaced with their families, and as they are getting displaced, they get into IDP camps where they are exposed to several insecurities, and one of the major problems is the gender-based violence, where they are sexually abused, they are being mimed here and there. And I think this is a very big concern to us as humanitarian workers to take some steps to addressing some of these issues. And then finally, under the key findings, we saw that 34% of the women were reporting sexual violence as the biggest concern, while 27% said they could not access GBV services. So the sexual violence is there. but the services are quite scanty. So these people are actually more exposed to challenges, including the psychological issues. And I think we need also to take control of this one. And I think one of the things which we actually saw under the humanitarian aid, the recommendations anyway, we were looking at, we felt that the humanitarian aid must expand and include local voices of the people that are basically having challenges, and we basically realized that 74% of the people in the places which we did this assessment, we are not receiving humanitarian assistance. And they reported that they are not received it in 30 days. And, they felt that humanitarian assistance should be extended to, these communities because of the stresses they are having as a result of the drought. And also, we saw that education is at a big risk, where 56% of the people, prioritize education as a core need, actually. We saw that over 30% of the children had kind of, dropped out of school due to COVID and the drought. And I think this is something also to take note of, especially, for girl child, actually, in these communities. And then women-run businesses have been hit hardly. And we realized that, 98% of the women reported have lost the income, and they have basically nothing to rely on. And I think that is also a very big concern. And then decision making is still dominated by men. However, we were seeing that new spaces are opening up for women, where we are seeing that at least 33% of the women were able to contribute to decision making, because during such crises like drought we are experiencing, women have to be at the center of taking decisions about some of the interventions, some of the situations, and what they want to see around them. And I think with displaced people, we saw that women basically can be of actually influence in decision making much more than even any other person, because they are the first responders. And what are the recommendations we are coming up with for this? We are saying that design should support multiple shocks, because we are working in a context where we have got multiple issues. We have got drought, we still have COVID as a challenge. Don't know where COVID is going. We don't see maybe the conflict ending soon. We are also having repetitive other issues like flooding coming. Today we may be crying about the drought, but flooding may come. So we want to see how maybe can donors increase humanitarian assistance to the Somali communities that have been affected by some of these issues, and they they should try to ensure that they target women, girls, pregnant and lactating women, elderly, and PLWs, because of the vulnerabilities they face. And then we saw one of the things we saw that was a challenge we talked about was around wash and health. We are saying installation of sufficient, safe, and gender-friendly health and wash facilities should be prioritized actually to protect women and girls from violence. Because one of the things I think we mentioned was the safe access to water facilities. Actually, during that walk to get water, that's when women get maimed, they get raped, and a lot of things happen there. So how can we come in and ensure that we are able to deliver safe and gender-friendly water or maybe health services, and ensure that we protect women and girls from this violence? And then create responses that include women and girls' voices and leadership, actually, because we have seen that women are the first responders in most of the disaster situations in their communities, but we do not involve them. We are saying, how can we come in and ensure that, as we design our interventions, our responses, women are put at the center of a response, and they are able, to contribute and lead during that process, and they deliver the much needed change of getting out of this crisis. And then the second last one is that we need to collaborate with and directly fund women, youth, and gender-focused organizations that are already responding to the crisis. Quite a lot of agencies are struggling here and there to respond to the crisis, but the appeals which have been forwarded to donors and other people that can support have not been honored. But we are saying, can donors and other people that are willing to come in and support, prioritize funding women, youth, and gender-focused organizations to be able, to help these women that are facing the much of, the vulnerabilities that are coming with this drought. So we are saying women and girls, young people, and other marginalized groups should have full, equal, direct, and meaningful participation. So let's, try to engage them and ensure that, they are at the center and they work towards, seeing that change. And then finally, there is need to invest in preventing climate-induced disasters and responding better, because we are grappling with this disaster, the drought, but we had drought in from 2016, 2017, we are undergoing another phase of drought, and then there was another one of 2010, 2011. These are quite, repetitive, but how can we, build some early warning and maybe some level of resilience where we say donors maybe come in and invest in gender responsive systems that could help, people withstand shocks, and, they are able not to get displaced when, such incidences of drought, such disasters come. So that is what we feel, that maybe if we are able to, in the long term, because today we may be grappling with this one, but another one may come, how can we start preparing and ensure that we build the capacity of the women and men, the girls and boys, and ensure that they are able to monitor and report around the signs that can help predict that maybe something is coming, and either we preposition or we ensure that we build the resilience of the communities to withstand these shocks. So that's it.
Martin?
Thanks very much. Yeah.
Awesome. Thanks, Martin. If you want to stop sharing your screen, we'll bring up the next presentation from Kenneth. And we had lots of great questions for you that we'll present at the end about the study. And Martin, just while we're sharing the screen, this study was, when was it implemented? What were the dates?
It was done in August 2021.
Thank you very much. All right, thank you. Our next presenter, we're going to head over to Kenya. We have Kenneth Kamandi, who is the programs coordinator at the Kenyan Red Cross, who have been frontline responders in drought-affected communities. And if we, Vivian, could go on to our first slide. And then also put it in presentation mode.
Hi, Jessica. It's in presentation mode now. Can you see it?
I'm not seeing it, but are others? Laureen, are you able to see it in presentation mode?
No, it's not.
Okay.
No,
no.
it's not.
1 minute. I'm going to reshare.
Thank you. We specifically had our colleagues from Geneva join us today, because sometimes we don't always have the strongest internet connection. So I'm secretly a little bit pleased to see this, that it might not be our connection this time.
How is it now?
Nope.
Oh, wow.
It's visible on my side, just to jump in.
Oh,
We can
I
see the
spoke too
screen,
soon.
but it's not in presentation mode. Let me try, Vivian.
Okay.
Yeah. And while we're doing that, yep, there we go. Thank you. I was going to go to some questions, but I think we will. I'll hand over to Kenneth. And Kenneth, you have approximately 10 minutes. So again, this is Kenneth Kamandi from the Kenyan Red Cross, and they are frontline workers in drought-affected communities in Kenya. Over to you, Kenneth.
Thank you very much, Jessica, for giving me this opportunity to be able to highlight some of the works that we are doing in terms of GBV response when it comes to issues of drought. Next slide, please. So we are having, based on the last year, this year ending year, that is the National Drought Management Authority was able to report that we're having 3.1 million people in 23 ASAL counties have been faced by drought activities within their different, alongside dry and sunny conditions since September 2020. And we are finding that following the drought, families have been unable to meet the basic needs, where we are finding women are being exposed to gender-based violence, including harmful practices such as FGM and early child marriages. And the girls are being forced into marriages due to lack of protection within the female households and because of some of the food security issues. And this has predisposed women to do long distance when it comes to in search of water and food. And this has predisposed the women and girls into sexual violence. And this is based on an assessment that we were able to do last year, that is through the Kenya Interagency Rapid Assessment. And then at the same time, we're having that there's some of the stressors and the property and communal loss that have led to the negative coping mechanism, which is in case of exchange of foods and water and for the other basic needs, which predisposes our women and girls to GBV. And at the same time, in addition, we're having displacement, which is caused by the drought, whereby putting vulnerable women and girls at a greater risk, whereby now they are able to assume the traditional male roles within their community, since men and boys have been able to move away from the households in search of pasture for their livestock. Then the other one is on the loss of women in terms of, we're having loss of assets, women at the household and personnel, including jewelry, being procured for food. And this has caused in terms of economic and social effects of the well-being of the women and girls within our community. Next slide. So out of that, in terms of some of the areas that we have identified and some of the gaps, we have been able to come up with some few measures that we are implementing as Kenya Red Cross across the different counties, not only just the 23 counties that have been affected in terms of the drought, but also other counties that we have within the 47 counties. And one of them is in terms of support coordination mechanism. This one we are able to ensure that there's a county gender-based violence working groups and training of the county coordinators in order to ensure that we are able to respond to issues and we're able to address some of the issues that we are facing so that we can have a synergy in terms of how we are addressing this, so that we have been able to support in terms of the coordination mechanism. At the same time, we have been able to build capacity of frontline healthcare workers on clinical management of rape. These are some of the issues, the emerging issues that come across when we're having issues of drought. It's not only less on issues of clinical management of rape, the other programming or the other support that we give them, that is the MISP, Minimum Initial Service Package. We're having issues of MHPSS that comes with issues of drought. And then the other bit is in terms of the toll-free line, whereby we are able to, it's a toll-free line whereby the community can be able to call and be able to get any assistance in an event they are having any issues. And for the Kenya Red Cross, we are having the 1199, and then subsequent in terms of referral cases, where we are having GBV cases, we have the 1195 that is being coordinated at national level. Then we're having the child line, we have 116, and then we're having counseling hotline, 1190, where we are working very closely with Amani Counseling Center, together with our telecounseling within the Kenya Red Cross premises. The other bit is in terms of the provision of referral services, especially for sexual violence. This we are looking in terms of the community structures, using the community health volunteers, but at the same time offering ambulatory services within the community where cases require urgent attention. Then at the same time, we are having the sensitization activation of community respondents, whereby we are having the community watch groups who are now supporting us in terms when it comes to issues of GBV. Some of the community's members who are part of the community health volunteers that we work with. Some of our Kenya Red Cross volunteers are part of this, that we have been able to sensitize and activate them when we're having these issues. They can be able to support even when doing referral, and also pass the messaging within the different communities within their jurisdiction. And then we are supporting in terms of the integrated medical outreaches. We are finding that during drought, most people are able to move from their normal areas. So we are ensuring that for the hard to reach areas, to bring closer services to the people, we are able to support in terms of the integrated outreaches. And this, we are not only just working as Kenya Red Cross alone, but we're working with other agencies, being supported by the Ministry of Health, different partners, having UNFPA, National Partner Society within the Kenya Red Cross movement, are able now to support us to be able to do some of these outreaches, just to ensure there's that continuity of services within our community, so that we are able to address that comes in. Then the other bit, we are having the pre-positioning of the distribution of interagency reproductive kits and the dignity kits, that we place them within our different counties and our regions. We have 8 regions across the country, whereby we are able to pre-position these kits, the RH kits and the dignity kits. In case of any eventuality from the crisis situation, we're able to respond. Some of these kits, we pre-position them, and we work very closely with them. Level 1 facilities, we work with them with the sub-county facilities and the county facilities, just to ensure there's continuity of service. Then the other bit is in terms of the cash and voucher transfer. This cash and voucher transfer is both for the community, where we are able to do it's in twofold. We are having the condition and the unconditional aspect to it. So the conditional aspect to it is where we are giving cash to the community to make a decision on what exactly they need within their household. So it gives them dignity. It can be able to, for them to know, if I require these certain items, I can be able to procure based on that amount of money. So currently we are giving at around 5,067 shillings. That's what we are giving the community. For the conditional one that we are having is basically the vouchers, the voucher assistance. So this one is more defined. You find that we give them a voucher maybe around 3,000, and they have to buy specific items that are within that voucher, maybe dry foods and the rest. So those are the two folds that we use in terms of the cash and voucher. And then we have procurement and distribution of the food and non-food items that we support. These are things like the kitchen set, we're having the trampolines, we're having the mosquito nets. So that's something that they can be able to use in an event there is issues, that they're able to move from one point or the other. Next slide. So some of the potentials and opportunities and recommendations that we have been able to identify during our period in terms of doing the response on this. There's a weakest cross-sectional integration of GBV, and this one we are looking at having different sectors come into play. For us to be able to address issues of GBV, it cannot be only a health intervention, but we need other sectors to come in so that we can be able to address these issues of GBV holistically. And this one, that's to ensure that we are having a food security, wash assessment are being done, so that we can see the broader impact of women and girls, to ensure that the programs are not only just are able to increase and address issues of the girls' risk on GBV, especially on the water points run by male gatekeepers. And then we are advocating for issues of resource allocation at the county level, does not prioritize on issues of GBV. So we are trying to advocate for that, just to ensure there is sufficient resources to be able to support the GBV programming. And then the gender inequality is worsened during emergency and pre-existing cultural norms. So we are trying to see on a focus in terms of the preparedness action in disaster-prone counties. We're able to sensitize communities about GBV risk, preposition some of the dignity mama kits, initiating the cash transfer assistance for vulnerable households, and then reach levels of acute insecurity and training of the first responder on the SARE policies that we have. And then the other one is lack of continuity of GBV intervention beyond humanitarian response. And this is now where we are looking in terms of the triples nexus programming, so that anytime once an emergency has taken place or we are responding, we're able to ensure there's continuity. So the structure that we have already built, they can be that continuous. The community can be able to pick it up in an event, either when a partner has pulled out or someone else is not be able to support, community can be able to bring some of their resources, and we can also to ensure that there's that humanitarian bit that comes out, there's a developmental bit, and then there's the peace actors who are part of this to ensure that there's that continuity of services of GBV interventions. And then some of the challenges, we have timely referral due to insecurity. Some of the areas that you're accessing, you find, yes, it's a hard hit in terms of the drought, but when it comes to insecurity, we are not able to access to the farthest end. So for this one, we are trying to work with the different state agencies, especially on the security matters, just to ensure that communities are able to access some of these services. And at the same time, in terms of the inaccessibility of the migratory community, because once they start moving, sometimes it's hard for them to be able to be tracked. And this we are looking in terms of mapping some of these migratory communities within the different counties, so that to ensure that if they have started services within this facility, maybe it's a facility within one of the counties, then when they're moving to the different areas or the sub-counties of that county, they're able to continue with the services because you're able to link them to some of these health facilities just to ensure there's that continuity. And then the other one is in terms of adequate resources for cash for transfer assistance and dignity and mama kits. So for the cash transfer, yes, this is monetary value. We might not be in a position to, as an organization, maybe to support entirely, maybe identify some of the specific households that are very needy, but at the same time, there are other households that may require this same assistance that we have. And then the other one is in accountability of the affected population, including addressing the issues of the SARE. So this one is in terms of just developing the tripartite nexus for the GBV programming. So where we are able to put all the players for this to be able to respond and to be able to be accountable to the people within our different communities where we are doing some of these interventions for drought. Yeah, thank you.
Thank you, Kenneth. I really appreciated one of your recommendations here, which is a focus on preparedness, which many of us know, many of our participants on the line come from countries who experience cyclical natural disasters. So I think that's a point well noted. And our next speaker is Justice Liku, who is the director within the Humanitarian Response Unit at CARE International, and Justice is going to spend the next few minutes giving us a broader sort of regional overview from a food security perspective. So the gendered response of food security sector in the Horn of Africa. Over to you, Justice.
Thank you, Jessica. So my presentation will focus on, as already mentioned, on the food security sector. And I will focus on some of the gaps which exist in terms of planning and responding in food security, which affect us being able to bring out issues of gender and protection, for example, like the GBV. So that is where I will focus my presentation. Next slide. So basically, for us to be able to draw a good response, food security response, we rely so much on the situation and needs analysis, which we do with the target communities we want to work with. But there are a number of challenges within that, with the kind of data which we get, which impairs us to make this connection with protection and gender. One of those, as we do the situation and needs analysis, one of it is that a number of times we lack sex, age, disability disaggregated data, simply because a number of places, they haven't carried out any gender, and barrier analysis. And this can be related to the kind of tools we use. One of the tools which is used in the region is the IPC analysis. And you'll find in the IPC, we haven't learned very well on how to integrate, to integrate the sex, age, disaggregated data and be able to use it in our analysis. One of our other tools we use is the FAO, EFSA, and we also use the WFP Food Security Monitoring Reports. Most of these assessments, they rely so much on household surveys. And when you do an household survey, it kind of masks, the situation or needs for specific genders. Like if we are talking about adolescent girls, if we are talking about women in specificity, if you are talking about female-headed households, if you are talking about men, if you are talking about the aged, if you are talking about the disabled. So you find the data available kind of doesn't reveal that, and therefore our responses doesn't end up addressing protection issues in a good way. One of the other issue again is detailed gender analysis, which identifies also, let me say, the capacities. So we kind of tend to talk about communities or talk about households where we don't go further to be specific on different capacities existing within the households, which could be a contributing factor in terms of addressing food insecurity. We also don't identify like, who are the key actors, like women actors, who could be influential in terms of helping us with response. A number of times also lessons learned in terms of gender equality and women empowerment may not end up in our assessments, and that also again affects our, that affects our planning in terms of bringing forward protection and gender issues. Choosing the people to talk to, again, you find that there are lesser women voices, and our analysis tends to be combined from a community perspective instead of taking these genders input separately and then doing an analysis separately. In terms of participation approach, again, a number of times you'll find a number of genders who did not participate in our assessments, maybe simply because of maybe the intent or time or cost. And the last one, which is also very important, is that we haven't developed adequate indicators which can support us in terms of measuring and analyzing gender outcomes, which are sex, age, disaggregated. So those are some of the key things which have been gaps and, affecting our link to gender and protection. And definitely we are now aware of them. And later on, I will be showing some of the steps we have been taking to try and cover these gaps. Next slide. So how does the kind of gaps I have identified in the previous slide affect our response? And one, because we weren't gender specific, then in terms of planning our response, we tend to move towards one size fits all approach. Like in terms of our, let's say, our ration for response, in terms of determining the cash transfer value and all that. Instead of being specific, there is a disabled person here, or there is an adolescent, we tend to combine it all together. And therefore, adapting an approach which fits, fits all. And that, makes us not be direct in terms of addressing gender needs for specific genders within a household. Another point is that it masks the understanding of relationship between the needs, the root causes, and the underlying vulnerabilities. Okay, because we did not go deep talking to different genders, really understanding what is affecting them, what they need. Then we end up not understanding some of their vulnerabilities because we weren't specific in terms of our research, in terms of our assessments. The other thing is that then we end up not understanding capacities existing within different genders, which would have supported our response. And a number of times then some of the marginalized groups may kind of be omitted and end up not getting response. Or even if we give them response, it's not really specific to their needs. Out of these, again, monitoring not able to reveal protection issues. And this is, I guess, this is the interest of this group. So because we don't go deep, issues of GBV, issues of sexual abuse, issues of access to health, issues of income levels for particular genders ends up not being revealed. And based on that, then our monitoring, we are not able to report on some of things like GBV protection and all that. The lack of SAD also affects effectiveness in terms of advocacy and in addressing protection issues. So if we had this information in terms of different genders, then our advocacy messages would be very specific on each of the genders, which will be more useful. But now, again, we tended to blow it from a community perspective, which is, again, generalizing everything in terms of being specific. Next slide. There are some of the steps we have already started taking into account within the food security community to address these challenges. And one of the things I think is what Martin was presenting, where already there are communities which are conducting the rapid gender analysis. And therefore, as a food security community, we have already started approaching the gender community to see how we can work together and integrate our work. How can their SAD data be integrated with our food security work in terms of moving forward and having better plans, in terms of even, the deeper investigation in terms of barriers, in terms of capacities, for different genders. So we are taking steps in terms of integrating with those communities to see how we can improve our responses. But yes, few steps have been taken, but I can say we are not yet there. In terms of the IPC analysis, we have already formed a small working group, and K is working with Oxfam, where we are trying to come up with an IPC gender guidance, and again, it's about how we can bring in aspects of RGS into our analysis to be able to improve our food security reporting and analysis. So some work is happening again there in the IPC. It may take some time, but I believe with time we are going to have something. WFP has also over time worked a lot in terms of integrating gender components in its food security and monitoring report. And that's another input which is used in the IPC. So good work again is going on. We are not yet there, but we are making steps to see that, we reach where we want to be. We need to listen to the women's voices and conduct the analysis separately. The previous report, like when Martin was presenting, I think he talked about individual stories. He talked about the focus group discussions. And yes, a number of steps are happening in terms of listening to the women differently, be it adolescent girls. But yes, we need to bring that into the food security analysis and integrate it together to get better results. CARE has been conducting like what we call the social analysis action, where you go deeper in terms of now specific issues like GBV, issues like sexual abuse, determining, levels of income for different genders, education level, literacy, health, and all that. And therefore, we are saying we need all that information to be brought into the analysis of food security for us to be able to address protection issues. The intervention modalities to assess the risks and opportunities, as well as their relevance to women and girls. So any of whether you are choosing cash, whether you're using in-kind, or whether you're using conditional like cash for work, it is very important to assess the risks which may be experienced by using such modality for different genders. And therefore, that would be very important. I think, yes, a number of steps, again, are being undertaken in terms of risk analysis. And yes, we are not yet there, but we know what has to be done. Indicators, again, which I mentioned earlier before, they're very important, and we are working, the guidance I was talking about on the IPC, we are looking at some of the indicators which could be relevant. And if we do that, then this will be able to reveal some of the protection issues faced by the communities we are serving. And we will be able to kind of isolate and, inform better on protection issues. The last one I would say is that in all our works and in all our coordination forums, we need to integrate gender specialists or gender focal points, be it we are carrying out an assessment or an analysis, or we are writing a report, and that will assist us in terms of improving our food security response. I stop there. Thank you so much.
Thank you, Justice. We're going to close now for questions, and we have about 10 minutes left for our questions. And I am going to put some light questions together for our speakers. I'll start off with Martin, and if you could very succinctly, we had a couple of questions about your, when you talked about access to services. So we had one who said, what are the main reasons that women can't access services? How can we improve that? And we had another participant that said, you mentioned 27% were not able to access services, and they thought that number was much higher than that, actually, as an organization working on the ground. So Martin, very specifically, what do you think are the main reasons why women and girls can't access services in Somalia, and how can we improve that? Martin, very quickly.
Okay. Yeah, thanks very much, Jessica. And I don't remember a person who mentioned, but maybe this question, you know, quite a lot of issues happen when it comes, to women and girls. Number one, women and girls are not involved in decision making. So decision making is done largely by, the elders and the clan the clan leaders, and then they actually isolate women and girls to be on the receiving end. So issue number one we saw was that one where women are actually at the receiving end. Then number two is the aspect that, women are more vulnerable, like, other, speakers have noted, like just as when disasters happen, you're going to realize that, men run away and leave women actually to manage on their own. And these women actually have to take care of the children, take care of, the elderly and everyone in their homes, and ensure that, they migrate them from the area of crisis to an area where they can maybe access services. So what we are talking about is maybe in these, spots where these women are coming, can we be able, to provide some protection services there, the services that will help them access, dignified shelter, the services that would help them actually access, let's say, food, and maybe they do not become so vulnerable because they have already run away from where they were and they have come to this location. They have no food, they have no access to water, and how maybe are we coming in to help them, access these services and ensure that, we arrest the situation before they are abused, they are exposed, to that vulnerability of starting to give all they have to be able to get what they can use to take care of the family members whom the men have left them with. So thanks very much, Jessica.
Okay, thanks, Martin. So two things that came out of that, I think what you said was, one, that female-headed households might be prioritizing other basic needs over accessing healthcare. And then also that when these basic needs aren't met, like food and shelter and water, it reduces their health outcomes and actually makes them more vulnerable, is what I'm getting from you. Is that right, Martin?
Yes, that's perfect, right.
Okay, great. And I think it's interesting because there was also a question about how can we improve, and the Kenya Red Cross, and it didn't come out as strongly maybe in Kenneth's presentation, but they're also looking at how pastoral communities can better access healthcare services. And if you noted in their last slide about gaps and then recommendations about making, and Kenneth, maybe you can give a little bit of information on how the Kenya Red Cross is making sure that you're increasing or improving access to health services among pastoral communities. Over to you, Kenneth.
Well, thank you, Jessica, for that question. So basically what we are trying to do, and we are working very closely with the Ministry of Health just to ensure there's that continuity of services. We are trying as much as possible to support the integrated medical outreaches that we are having been done within the different communities. Especially in the hard to reach communities, whereby we are ensuring that all services, the community can be able to receive some of the services that they are having within the health facility, within the static health facilities. So, and the other thing that we are trying to see is just to ensure that the referral mechanism is very strengthened for us to ensure that they are able to get these services within the shortest time possible. Yeah, thank you.
Thanks, Kenneth. So maybe some lessons learned for our Somalia colleagues from our Kenya colleagues about how they're increasing access to healthcare. Kenneth, since I have you on, another question for the Kenya Red Cross would be about people were very interested in your cash and voucher assistance, and we've heard that as a common intervention for drought affected populations, both in Somalia, Kenya, and in other countries as well. The question is, there was two. One was, have you been able to link cash and voucher assistance to a positive impact on negative coping mechanisms? So the question would be, those that have exposure or access to cash and voucher, are they more likely then to, or less likely then to have to rely on negative coping mechanisms? So has there been any data around that? And then the second one is, what are some of the conditions versus unconditional criteria for your cash and voucher assistance in Kenya? So Kenneth, a two-part question on cash and voucher assistance. Have you seen a positive impact in terms of reducing negative coping mechanisms due to cash and voucher assistance? And the second is conditional versus unconditional criteria. Over to you, Kenneth.
Thank you, Jessica, and thanks for that question. For now, I might not say we have exactly in terms of the study or the assessment, just to say widely how it does have that positive or the negative impact. But what we have seen is now we have been able to give people within the community the dignity to be able to buy items or procure items that they are willing or that they are missing within their specific households when it comes to issues of drought. So what we are trying to do currently with the cash voucher is just to give that point of the dignity aspect to it. So I might not be able in a position right now to say that these are some of the positive in terms of an assessment, but that is something suggestive and it's very good that we can be able to pick it up and just have that a bit of research just to understand how well it has been able to impact the community that you have. On to the second question in terms of the conditional and the unconditional. So for the conditional in terms of the voucher assistance, still it goes further where we are having restricted and unrestricted aspects to it. So for the conditional where it's restricted, this is whereby we are finding that we are having, yes, the voucher itself, given that this is amount of money, maybe let's say this is 3,000 Kenya shillings, but it's defined what you need to procure. But at the same time, with the voucher assistance that is unrestricted, it is not defined. So what usually dictates what method are you going to use or what approach are you going to use? Sometimes it's the availability of resources that we have. Then at the same time, it depends on the market assessment that we always do within this different community. If there's availability of some of the basic items that are required within the households, then that one can also inform on what aspect or what direction to take. Should we do the restricted or the unrestricted when it comes to condition voucher cash assistance? But as an organization, we are trying as much as possible to move towards the unconditional, whereby we are giving cash to the community so that we safeguard the issues of dignity, give them an opportunity for them to be able to utilize this money for the things that they require within their households. Yeah, thank you.
Thank you, Kenneth. And it would be interesting to see some studies on the impact of cash and voucher assistance in drought impacted communities. And maybe that's something we as a regional working group can look towards. Last questions. I know we have 2 minutes left on the hour, and these are to Justice. I think one is a comment, one is a question. The question is, what makes it so challenging to modify IPC assessments? Because it sounds like, Justice, you've been going through some working groups, some sub-working groups on how to do integration of gender. And the last one I wanted to, our colleague Josephine, it's not really a question, but I think it's more of a really great statement, is that sex and age disaggregated data shouldn't be the goal, that we should look towards gender equality and social inclusion, because also just sex and age disaggregated data doesn't tell us or give us, you know, the full picture. And I really liked I really liked the way that Josephine put that in the comments, and I thought it was a really good one. But the question for you is about the IPC assessment and why it's so difficult to sort of change some of these ways of working. Over to you, Justice.
Thank you, Jessica. Very great question. Let me say, I think some of the things I mentioned before, like issues to do with indicators, that is one of the issues we are trying to make proper indicators, where data can be collected and can be used in the IPC analysis. So the indicator aspect is one of the issues we are working on and had not been concluded, and therefore becoming difficult to include that in the IPC analysis. One of the other key things also, whereas we can say there is some data existing like RGS in a number of countries where we work, but you find actually the area of coverage of that data, it's not adequate to cover all the units of analysis the IPC is covering. And therefore, you would find that data is only partial and therefore doesn't meet the analysis of all the units we are doing. And therefore, it becomes very difficult to integrate it in the final report in terms of, like everywhere, this is how we found the gender issues were. So that's another big one. And unless we are able to conduct our RGS or any gender integration from all the units where IPC analysis is being done, then that will continue to be a challenge. The other thing I want to say is that in the IPC analysis, we use the available existing data from partners on the ground. And therefore, most of the places, if there is no RGA or gender information to be used, then we don't integrate it because it's not available. And that has been one of the big challenges in most of the places. Again, also, even when, let's say, like a gender information is available, like the RGA, I think in terms of working the analysis aspects on how to integrate that with the existing information and bring out the analysis. I think these are some of the things which have been kind of not hindered, but let me say, delayed IPC being perfect in terms of bringing in the gender outcomes. But yeah,
Thanks,
those are some of the key things, but there are more details and I can provide that. Mm-hmm. Yeah.
Okay, thank you, Justice. On that note, I just wanted to comment that one, I think that would be a great project for a GenCap, who's a GenCap advisor, if we could get one for our region to look at how we integrate a more gender-focused approach to the IPC severity rankings. And also that it is not just about the gender community or the GBV community, it's also about our food security and WASH colleagues ensuring that those gender components are integrated into their existing assessments as well, right? So it's both ways. If the information doesn't exist, then we also have to look at why and who's responsible for ensuring that it is. So great thoughts for us to think about, Justice, and we appreciate that. Thank you very much to our presenters, specifically Martin from CARE Somalia. Thank you very much. Thank you to Kenneth from the Kenyan Red Cross. It sounds like some great information there about cash and voucher assistance and other types of interventions by the Kenya Red Cross. And thank you, Justice, for bringing in a more food security focused view of this issue, which is the impact of drought on women and girls, specifically from a protection perspective. As noted, we will be sharing the PowerPoint presentations, a link to the recording, and to CARE's gender report, rapid gender assessment. To all those participants who registered, we do have your emails on file now. Please, if you would like to join us next week, we will have another webinar specifically focusing on coordination in Ethiopia. So we will have some elements on the drought, but of course we'll be focusing on the entire response in Ethiopia. So please do look out for the invitation for that. And we hope to see you online next week. Thank you all for joining us for this March presentation for the Emerging Practice webinar series. We hope to see you next month where we have a new topic for our Emerging Practice. Thanks again, everyone, and have a great afternoon.
Thank you, Jessica.
Thank you, Jessica.
Thank you all.
Thank you. Bye-bye.
Thanks, everyone.